So we will continue with the discussions on today's agenda. People are coming into the building from the coffee break. Amy, I see you're already online. Can you just check your audio? Is it working well?
That's exactly what I was just going to ask you.
Okay, wonderful. It is working well.
Good.
I can hear you very well. Great. So Amy's already here with us. So I think we should probably start because we have really a packed couple of discussions in the next 1.5 hours. This is our last run in the day. So Amy, we still don't have everybody in the room. I leave it up to you if you want to wait a little bit longer or if you want to start. Like we can wait 1 or more 2 minutes. And then we can delay the other presentations as well, like for 1 or 2 minutes, just so that you will still have your time to present if you prefer.
Gus, I would like to wait because I think there's a critical different framing for ZIP that I want to start off with before people come back in.
Wonderful.
So
So wait. I will go
so.
outside and call people in. Yeah, I see
Thank
in the
you.
room in the virtual environment we still have some people there waiting. I ask you all to be patient because it's been a really packed day for everybody here. I think people wanted to have this break, so I will call them in. Sorry. Yeah.
With some tea?
Amy, I think now we have a critical mass. We have most people in, 1 or 2 outside still, but I think now we can finally start. It's over to you. Thank you.
Great, thanks so much. First, I want to give everyone my apologies for not being in the room. I'm looking at the video and seeing so many people I wanted to be able to connect with. So I have a little bit of FOMO for not being there. Gus, would you turn me to the next slide? Or whoever's doing the slides? Thanks. So I want to frame things a little bit for ZIP because it's a very different type of program than much of what we've been discussing. And I was intrigued in our last discussion. Hope, I think you raised the point that we really need to also think about the systems change pieces. And that's really what ZIP is pushing the boundaries on, I would say. So ZIP under 5.0 was established with the board recognition that the Gavi support model works through national governments and that there's an equity imperative to reach beyond governments where there are systems failures, governance crises that preclude health systems from serving missed communities. So this is a specific kind of missed community. And the examples that are on this slide show the kinds of places where we are currently working. On the right-hand side, you see the countries. The work is being led by 2 consortium. IRC is leading a consortium called REACH in the Horn of Africa, and World Vision is leading a consortium called Race for Sahel in the Sahel. And on the left-hand side, you see 6 examples of contexts where ZIP has been applied. ZIP is an option that only gets exercised when the government health system cannot provide full immunization to children. And something that is unique about this within the humanitarian sector is that we are striving for full immunization for children up to age 5 years. And I'll talk a little bit about some of the constraints that we have found that will be of interest to you all. So I'm not going to be able to explain everything that's happening within ZIP, but I want to make sure we feed into the discussions that you'll be having tomorrow. So next slide, please. The impact of ZIP through June 2024, our implementation started with different countries coming online and even different health areas, local government areas, or sub-districts coming online at different times. So far, 850,000, I'll round up if you'll allow me. Children between the ages of 0 to 5 years have received their first dose from ZIP programming, putting them on the path to full immunization. As of June, again, all of these numbers are a little bit stale. As of June, 350,000 of those children were past their first birthday when they received their first dose. Nearly 500,000, and certainly now in September, more than 500,000 children have been fully immunized by ZIP, and that's based on the last dose that's available to them by age in their country. And of the doses that we track, which I'll speak to in just a moment, nearly half have gone to children under age 1, and nearly half have gone to children over age 1. Next slide, please. So these are showing you the doses that we track. We are receiving data at Gavi from the 2 consortium on Penta 1, Penta 3, Measles 1, and Measles 2. All doses within the national schedule are delivered within ZIP as allowed by age, and all data that is required by the national health system is also reported through national data systems. So to keep the data reporting light, we are not receiving information on all doses distributed. I do want to just take a second here to narrate the graph that's on the right-hand side. You'll see this color scheme throughout the remainder of the slides, where we have infants 0 to 11 months in the darker blue, children between the age of 1 and 2 years, or 12 to 23 months in the royal blue, and the oldest children, 24 to 59 months, are in the green. These are the full set of doses that we track. Again, KPIs is what we call them, from December to June 2020, December 22 to June 24. Next slide. So I want to just pause and talk a second about the uncertainty of living beyond government reach. There are different ways that governments are pressed to really strain the health system to a point where the health system cannot function to deliver immunization services. In some cases, this is through a natural earthquake or other type of crisis that does not affect governance. So if the government can continue to provide services, even with assistance, that work continues to go under the One Country program. Where there is a governance crisis that really requires independence and neutrality with humanitarian principles and requires Gavi's systems to look, or the alliance systems to look beyond the One Country model, that's where the ZIP option is acceptable. Now, what this is really trying to illustrate is that there are people that move between different areas, and individual areas move sometimes very rapidly from one situation or one context to another. So you might have an area that's recovering post-war and then becomes a semi-autonomous region, or is occupied by non-state armed groups, or descends back into the war that they had previously. The ability for humanitarian programming to navigate this with independence and neutrality, to navigate it safely, and to apply humanity and impartiality to the peoples that are living in these areas is absolutely essential. And it's really what we've been able to demonstrate within ZIP. Next slide, please. So humanitarian ways of working bring us a new set of principles and practices that right now do not naturally fit with EPI programming. And so we really are working to apply these humanitarian practices and find out what humanitarians need from the EPI community and from the Alliance. Humanitarians offer neutrality, as I've already mentioned, negotiated humanitarian access. I'm not going to read through this whole list, but what I really do want to convey here is in the 30 years that I've been working in global health, these principles and practices represented new ways of working to me. And I'm sure that for many people who have been really dedicated to the global health development technical assistance model that puts the government at the centrality of the work that we do, these humanitarian principles challenge us to think in new ways. Next slide, please. So this is an example from ZIP that I want to share from South Sudan. And one of the things that's really remarkable about this is not simply that a BA is a contested area between Sudan and South Sudan, but also if you look at the map, you'll see a BA is the highest kind of at about 12 o'clock, if this was an analog clock face. And this is an area that has received a considerable number of refugees from Sudan. So as the Sudanese conflict and war has disrupted the population, especially in Khartoum, but all the way throughout the country, many people have fled to areas in the south, in South Sudan, and a BA has received a large number of refugees. There is a presence of armed militia. So the area itself is contested. It's an administrative area of South Sudan, but it is contested with Sudan. There's a presence of armed militia from both countries. And what this really means is that there is a reluctance on both sides of the border to invest and strengthen the systems within South Sudan, within ABA. South Sudan is providing vaccines, but there's a fundamental question about how to strengthen this system in ways that fill the gaps and allow the flexibilities for changing contexts as conflict and risk ensues, but also as there are questions about how this will, where this will fall ultimately. The point that I really also want to make with this slide is not just to illustrate the difficulties, but to show you the success. So ZIP started here only in January. For a number of reasons, this was one of the last areas that we've entered in 2023's work. So they started in 2024, and they very quickly have already achieved, while they're small numbers at this point, they have achieved a very considerable proportion of immunization for the children who are among the oldest from ages 2 to 5. And what also is remarkable here is there is very high demand, but there is not great awareness of the fact that these children are eligible for vaccination. Next slide. I want to share with you all some real issues that we have seen as barriers where there is, again, a systems need and I think a coordination need for us. This is on the catch-up eligibilities within the countries that we work in. The illustration here is from the Sahel. One thing I want to draw your attention to in the graph that shows Nigeria is that you see no green here. And there is no green because there is no access to pentavalent. There is a restriction across the country to not deliver pentavalent vaccine within catch-up vaccination for children above age 2. So this is something that holds back catch-up. And while this is an issue for the whole country, it's particularly an issue in these ZIP areas where we know that there have been different reasons that children haven't been vaccinated that we want to overcome. So I won't spend a lot of time going through the details of this slide, but I do want to really flag that we have had meetings with the Big Catch-Up Working Group to pull this out and to pull in the need for us to both give advice on, as well as for ZIP to get special privileges or waivers where we can vaccinate. And Daniel, I want to call attention to the question that you're asking too, and make a note that routine is also, in almost all cases where we're working, there is a separate schedule for ages above age 1. And so following the 2 different schedules is something that we have navigated throughout, but also getting those special permissions is key. And you're hitting, Daniel, on exactly the issues that we have around preserving supply, and extending access to catch up. Next slide, please. I want to try to keep us on time. I'm already over, I think. Gus, give me a time check.
You still have 2 minutes, but you can go a little bit beyond if you need.
Okay, I just wanted to make sure since we started a little late. I see now my clock. So these are some of the lessons that we want to share with all of you. And forgive me for not being able to illustrate each one of these with a data slide. I wanted to make sure that we spent enough time with the discussion. The illustration is showing routine and catch-up schedules. This is illustrative and shows also in the gold the KPI doses that we're tracking. So what we're typically finding is that there is the routine schedule, and then there is either a proposed or approved catch-up schedule. In some cases, there is a catch-up schedule that is different by month age groups. So Burkina, for instance, has different schedules for different ages. And in some other cases, we are seeing that there are exceptional schedules for catch-up, and those also may vary by state. So in Ethiopia and Nigeria, we've been able to negotiate specific catch-up allowances by regions and states. One of the first things that we quickly learned was that there was a misunderstanding, and I'm now looking at the green text on the left, that there was a misunderstanding about what our objective was because of the notion of zero dose. And we needed to change our messaging with our implementers and with the national programs that we were working with to make sure that we were emphasizing full immunization, that every child who gets their first dose from ZIP or their catch-up doses from ZIP should be moved through that schedule to full immunization, either according to their catch-up schedule by age range or the routine schedule if they were starting with us on track. We also recognized then that the routine immunization could not be undermined. And this was another piece. We had a lot of cases where people were proposing going house to house to find the zero-dose children. And when they were going house to house, they were not able to also maintain and build back up the routine immunization that had also been neglected, which had originally produced the zero-dose and under-immunized children. Another key piece that we have found is that our work to identify and understand the determinants of individual or household level zero-dose was distracting people from focusing on understanding how to identify the missed communities. We have found, and again, we're in a unique set of missed communities, but we have found that it is more useful to look at the historical gaps in programming as a marker of need for our communities, rather than to go by either estimated or modeled or admin data and survey data, because these kinds of communities have been cut off. And so all of those data sources will underestimate what need we know. And if we instead work and say, this community, like Tigray in Ethiopia, has been cut off for a specific amount of time because of a protracted conflict, which war and then recovery, it allows us to go in with a better understanding of where the gaps will be and plan for those gaps at population level or at community level, rather than try to seek and address individual zero-dose children. That also allowed us to reinforce the messages above around full immunization. I believe this was my last slide, but will you take me to my next slide, please? So here's an example from Kaduna State in Nigeria, where the Chan group in the Sahel, so Chan is, I'm going to get it wrong, I'm not going to say it, the Christian Health Alliance of Nigeria, which manages health systems, and immunization was a new piece of work for them. So working with them to develop humanitarian approaches and to bring immunization within the communities was a new set of skills that World Vision helped them develop and set up the systems to deliver. I will stop there and thank you for your time.
Thanks a lot, Amy, for this very interesting presentation and impressive results that you were able to get in just 1 year, in less than 1 year, I think. Very impressive numbers. We do have already some questions coming in the Q&A box. So I will start with those, and then I can also open here in the room for some discussion. I think some of the questions that I'm seeing here are related to the definition of like zero dose and the age groups. There is one question about like if the chunks of 12 to 23 and 24 are above were missed from the program initially. So this is one question I think is related to the catch up and the conditions on the humanitarian settings. The other one is related to if you know how many of these children were vaccinated in these areas prior to the Z program intervention, like how many of them are really would be zero dose by the definition. I think that highlights this whole issue on like the challenge with definition of zero dose in these areas. Can you talk a little bit about that?
Happy to do that. So we have spent time working on a definition of zero dose that we use for our ZIP programming, with a recognition that some of the countries use a different definition. So I want to use the example of Nigeria and say when Nigeria talks about zero dose, they're talking about any child who's effectively behind schedule. It hasn't received their first dose by a younger age. So they have infants that are zero dose. I'm going to put that off, and I'm going to talk about what ZIP discusses as zero dose. Because we want to also ensure that we are establishing routine immunization, we discuss programming for infants 0 to 1, and we do not consider those children to be zero dose by our definition, even if they have not received any doses of vaccine. So what we're doing there is saying those children are eligible for the routine immunization schedule in every country that we're working until they are to age 12 months. So therefore, the routine immunizations programming needs to be strengthened and reinforced. So we are very clear that the routine programming needs to be established and that infants should be brought in through that. That is not to say that's a different type of, or a different outreach or different mobile. It's simply to say that demand generation and the work with the community to discuss eligibility really needs to make sure that we're not undermining routine. For all of those that are over age 1, we refer to them as zero dose. But again, our emphasis here is to meet every child's needs. So we don't really belabor the discussion about whether they're zero dose or under immunized, because at the programming level, they're working with the vaccinators to understand eligibility up to the age that's agreed with their national government. They're working to establish ways of ascertaining the child's needs and bringing that child to full immunization. So we really have found that tracking is critical to have the differentiator, but that in terms of programming, we really want to encourage that full immunization and not get people stuck on zero dose. Again, because we had real problems with that at the beginning. We had very clear outreach techniques that were not sustainable across the limited access of humanitarian contexts. So for instance, getting onto humanitarian flights, you might only be able to do that once in 6 months. We wanted to encourage the ability to navigate and make sure that we were addressing full immunization needs and not leaving children under-vaccinated, despite the fact that considerable efforts had been made to reach that community. There has been a considerable discussion on denominators. There continues to be a considerable discussion on denominators, both for our targets and for our programming. again, to balance that work to try to get to the zero-dose children versus establishing and maintaining a routine. So one of the things that we have been working to develop, and IRC is taking the lead on this, is a set of rapid assessments that can be used in communities, and also ways to kind of watch the data that is coming in and be able to learn from different patterns within the data. So when we get to a certain level and we know that we've been working in a community, one of the first things we need to do is know, have we mapped that? Like, are we missing an entire settlement? That would require us to go and work in that settlement. But once we get into the settlement, then we need to use on the ground methods and make sure that we are being realistic, and also make sure that we are continuing the efforts. And that also includes supply. And there's a real issue with supply, especially where we're vaccinating up to age 5. And local estimates for supply requirements had not included the older children.
I think this is a very good example of a mixed community where a routine immunization indicator may not be entirely adequate to track, because those are really like the core of what we're trying to do, like reach these communities under multiple vulnerabilities. Those are clearly communities under multiple vulnerabilities. And we need to be a little bit flexible and creative in the way that we track program results there, because of the nature of it. And we are learning as we do it. And I think there is a need there, like for some adaptation, some adaptability on like the situation in the ground, even in the vaccine procurement. I think there are some questions here in the chat. There is some validation for the catch-up approach of having like these policies clearly kind of set out and to be able to vaccinate above the year of the 12 months. And there is some concerns about the vaccine procurement in these areas, because if you use the regular denominator, then probably we will run out of vaccines before we can finalize. So do you have any perspective on that and how we are kind of going about it?
I do. I also want to make sure that I call out Chantal McGill is with Core Group, and she is working directly on the ZIP full-time as well. So I want to also call out that Chantal is responding to some of the queries in the chat. So vaccine supply is really actually interesting. We have a few cases where we are working in semi-autonomous areas where the vaccine supply needs to be negotiated by our implementers to figure out which country should be giving those vaccines. So in the example that I showed you with Abiy, the vaccines are coming from South Sudan. There are also areas that we are working in that are semi-autonomous, which are not examples that we share publicly, but where we have had to procure vaccines from UNICEF supply divisions specifically for that area, because neither of the bordering countries were willing to provide the vaccines for that area. So I want to call out that there are some larger issues at the kind of national supply level. We have worked with our implementers to make sure that as they are doing the estimates, they are all of need up to the ages that they know they will be vaccinating. And we're not always vaccinating up to age 5, because in some cases, as I said, there are caps. But they're working to do those estimates independently, or I shouldn't say independently. They're working to do those estimates as a vaccine forecasting for the older ages with the National Immunization Program. So the National Immunization Program may have done their annual estimates only based on one birth cohort. When our team goes in, they need to take those additional birth cohorts into account. And then they need to be monitoring supply very closely to make sure that they're not causing disruptions. Having said that, I am absolutely aware of places where we have caused stockouts at a small level within a specific context, and they have needed to remedy that very quickly. We hope that that is a mistake that will only be made once in one locality. So it's something that we're really working as we are ahead of the curve on this, and frankly, working ahead of catch-up policies in many places to ensure that we're not causing additional disruptions.
I am sure there are critical lessons learned for the Alliance on that specific component on forecasting in humanitarian settings. There are also some questions related to, so we still have 5 minutes, but Let me try. We have more 3 or 4 questions. I don't know if we have time to answer all of them. If you don't, we can go back to that later after the session. One is related, did you had any success in changing the policies on catch-up in those countries?
We have indeed. So again, I mentioned that we do have waivers in some places. So there's a recognition in some places where they have said, this is a circumstance where good example is Ethiopia. I'll use that as an example. So Ethiopia has been working on extending the eligibility for catch-up vaccination and deciding, every country is deciding what their catch-up policies are going to look like. I think it's important to call out the fact that in terms of national policies, it's very rarely one voice or one technical recommendation that actually affects a policy. So I think there's a real need for the Alliance to work together on these and to make sure that we are thinking about the different touch points and how we can engage on those. Where we have worked with ZIP, I will say very clearly, we have not attempted to change or affect national health systems. And that's going to sound anathemistic to many of you because that is the primacy of the Alliance and the One Country program. But because the ZIP program is actually working beyond the government, where the health system is unable to serve, we're more focused on filling those gaps and ensuring that the program can be delivered safely with humanitarian principles, rather than using the ZIP resources to affect change at the national level. We do, however, partner very closely with the Gavi country teams and ensure that our alignment on advocacy and other issues that come up is done in a coordinated way where the country team is working with the national government. So what we don't want to do is have a local implementer influencing up, on their own. So I think it's a different model. And yes, we've had success, but it has always been with the Gavi partnership and the country team and Alliance partners.
Thanks a lot, Amy. There is another question related to trust towards service provided by the government in this crisis context and how the ZIP consortium is working to build trust in these mixed communities.
Absolutely. So trust is one of the biggest issues that we have. I would say at the community level, independence and neutrality has been something that has been absolutely essential. Going out in a government vehicle to do immunization programming in an area where the government has been targeted or where the government where the population is fearful of the government does not work. Building trust in vaccination and building trust in the health system delivery is absolutely critical for us. So we are very aware that through community alliances with key stakeholders, negotiating access and also influencing from the community level wherever that is appropriate is essential. And it needs to also help build the trust for the government where that is appropriate. If there is a place where we are working again, where the government is not able to be present, achieving that trust in the immunization intervention itself is also paramount, or I should say tantamount, on equal footing with.
Thank you. There's a final question here in the Q&A box related to data and receiving data from consortium members, and I would guess like even sharing the data from ZIP. Like, what are like the challenge you have with data sharing, like the uncertainties in the intervention zones, the lack of trust, and then if you had any kind of a standard approach or mitigation strategies?
So the standard approach is, for us at Gavi, is very key that this is managed within the 2 consortium. So IRC works with local partners, IRC, International Rescue Committee, lends the support and the data system. In the World Vision Sahel program, Damagi was doing a lot of the data system building, but World Vision, again, receives all that data and reports to us on the KPIs, We also get narrative reports, and we have other grant management accountability tools that we use. All of the data, as I said, that it would be reported through the national system is also supported through the programming that World Vision and IRC provide. There is a case that is, as I spoke of earlier, a semi-autonomous region where we are very protective and do not share GPS. I don't even know the GPS coordinates for this place. We are very sensitive there to the needs to keep confidentiality and ensure that the data is not misinterpreted or misused. So I think we have a higher level of protection, and we are able to follow the models from our humanitarian partners to ensure that we do that, and that we achieve, again, different ways of working from what we would be used to with global health, where we ensure that all data is as public as it can be. We want to ensure that we have public goods. In this humanitarian programming, we need to follow a different set of principles. And that's probably a good place for me to end, Gus.
Thank you. Thank you a lot. Thank you a lot, Amy. I think we are really now over time. There was a question that Katie wanted to ask, and Judith probably as well. I don't think we have time for that now, but I would suggest you probably type that in the chat. And I think Chantal and Amy are online, and they're going to be answering questions after the discussion as well. Thank you very much.